And some of the
Thank you
stuff is
all for
old,
coming
you
out
know,
today. We
and I
really
love to read
appreciate
the
it.
comments.
Yeah.
We'd like to get
Yeah.
started. We have a wonderful panel of experts in the room today that we're really looking forward to hearing from. And we have our fantastic moderator, Benita Zahn, who is joining us today as well. So thank you all for listening in. I hope you have some takeaways from today. And Benita, I'm gonna pass it right over to you.
Great.
And we will get started. So thank you all.
Thank you, thank you. It's good to be here, and I think you all know why we are here. The numbers of people who are impacted by the Medicaid cuts, millions really, will lose coverage. They'll have reduced access to health care, which in turn becomes more expensive, because by the time you get to the care, it has become more advanced. Significant economic and healthcare system disruptions. In short, the big beautiful bill is anything but for a large segment of our population, and that's why we're here. And the cuts are being phased in, as you all know, with the heaviest impacts projected from 27 and onward. And this is information I haven't made up. It's all easily accessed and referenced. I'm all about the references. You know, we talk about work requirements and eligibility redeterminations and hungry children, and we know that hungry kids can't learn as well. So I'm not going to belabor. We're facing a challenging and interesting time. Joining us to talk about, and the topic today really is when the safety net Frays community health centers on the front lines of Medicaid. Joining us for the conversation is David Shippee, the president and CEO of Whitney Young Health. He's got over 30 years of healthcare management experience. Currently, as I said, the president and CEO of Whitney Young Health. He spent 20 years before as the CEO of Chase Brexton Healthcare, which was Maryland's largest community health center organization. It was also one of the country's largest community-based providers of care to HIV-infected people, and that community also stands to be greatly affected. He's currently on the board of the Community Healthcare Association of New York State. You know that as CHCANYS, the Healthy Alliance, formerly the Alliance for Better Health, and HCSCNY, Northeast New York Regional Health Information Exchange. I think this crowd knows all those letters, right? Otherwise, we have to come along. So, David, thank you very much for joining us today. Also with us is Kate Breslin. She is the president and CEO of the Schuyler Center for Analysis and Advocacy. And I said to Kate, how long have you been there? She said 16 years. And we're going, oh my God, time really does fly. She's assembled and leads an exceptional team at Schuyler Center that's building on the organization's history as a strong, independent voice and coalition builder that holds government accountable and helps shape public debate around policies affecting New York children and families. Prior to her work at Schuyler Center, Kate was the director of policy at CHCANYS, and she worked in county government, community-based organizations, and in relief and development in several African nations, including, fascinating, as a Peace Corps volunteer in Sierra Leone. So if you're ever on Jeopardy and you need to know, that's the question that will win you or lose you money. Marie Mongeon is the senior director of policy at CHCANYS, where she leads CHCANYS policy and advocacy team. Marie promotes the work of federally qualified health centers, protecting their ability to deliver high-quality care to New York's underserved communities, including in response, of course, to the COVID pandemic. We're all going to show up and bring you protein shakes. Prior to joining, because you need the strength through this, prior to joining CHCANYS, she was a researcher at the George Washington University Milken Institute School of Public Health, and she also has experience in health information technology and policy research. I've shortened everybody's bio because we would be here till lunch. Suffice it to say, everybody is an expert. And then also with us is Dr. Kristen Navarette, Commissioner of Health for Albany County, and leading the Albany County Department of Health's public health strategy and operations to advance the health and well-being of the community. Prior to the current role, Dr. Navarette also served as Senior Medical Director of Quality and Whole Person Health at MVP Healthcare. She holds a deep commitment to service and leadership, reflected in her broad roles with the American Red Cross and other. She's also assistant professor at Albany Medical College. She was recognized by the Capital Region Chamber Women's Business Council as a woman of excellence. And I'm going to do just a little self-promotion here. Many of you, if you have taste in class, watch Channel 13. And you know that I was the long-time anchor and health reporter there. But in the ensuing 5 years since I left, I am nationally certified as a health and wellness coach. And I work through, but not for, Capital Cardiology Associates. And so I have very much stayed on the forefront of health care delivery and support, and I still read all that stuff. So I'm either a bore or the best person to talk to at a cocktail party. So we know what the stakes are. In one sentence, what does it mean practically for the phrase safety net when we say it is fraying? And you may want to couch it in the senses, what does that look like for a patient who walks through your door tomorrow? And I'm going to start with you, Dr. Navarette.
Sure. Well, for me, I think of the net, and it has all the weavings together, and when it's fraying, it means each one of those are getting thinner and thinner and unable to absorb the increasing pressure of the system. And so what that practically looks like is delays in care, worsening health outcomes, and an unhealthier community in the long term.
For the 80 federally qualified health centers across the state that serve 2.5 million New Yorkers, it means $300 million in annual losses. It means more people coming to their doors who are uninsured, and it means fewer supports in the community for those patients to get care outside of the doors of those FQHCs.
So Medicaid is an important payer for children, and we expect children lose coverage, but we expect also a lot of adults to lose coverage. And we have very clear evidence that when adults lose coverage, kids are less likely to get the basic preventive care that they need that can keep them from having lifelong health problems or urgent or emergency care needs.
So the imagery of Dr. Navarette's net, I'll think of a fishing net. So pre the Affordable Care Act here at Whitney Young, we had a really big net. It was the biggest you could get, probably short of commercial fishermen. We were able to shrink that net over a period of time with the provisions of the Affordable Care Act. So the best example I can give you is the year before the Affordable Care Act kicked in, Whitney Young, 28% of the patients at Whitney Young were uninsured, not underinsured, uninsured, nothing. That went down to its current rate last year of about 8% of our overall patient population were uninsured. So that tells you how big a deal it was. So we were able to kind of get a smaller fishing net for a period of time. We need to go out and buy a lot of big nets now because we know as of July 1st with the essential plan folks coming off, that's the first. Those are traditional working poor folks that were over 200% of poverty. That's the sweet spot for a lot of community health centers, particularly rural community health centers. And so we know that that those are the days that we are probably going to be looking at is that bigger net, and the small ones we have now will fray really, really, really quickly.
I want to ask, in terms of healthcare providers in all of this, as you have to make a bigger net, and the folks who will be coming in, as I indicated, and you have all alluded, may be coming in later in the disease process and need more care. Do you have the staff to do this? Is there a pool large enough to provide this care in this environment? I see the look on your face.
You know, I think this is hitting at a very unprecedented time with a lot of converging factors. And I think you are really hitting on healthcare workforce is a topic that's been a conversation even prior to the pandemic, but especially post-pandemic. And so to have a system that is starting to fray and having less investment at the same time, we're having critical workforce challenges related to burnout, having adequate capacity, it really makes for an unusually unprecedented time and challenge.
Well, we're talking, Commissioner, from a public health standpoint, what's the difference between a temporary funding gap and a structural collapse in access?
Yeah, so I see a temporary gap as really about the cash flow. It's sort of about that day-to-day, do you have enough cash for the operations that you need? True structural collapse and access is when that safety net no longer functions as a safety net. There's a big hole, we're not actually doing what
The
we're
net
serving
that
to
David's
do.
been
Right,
talking about.
exactly. You know, I think we are somewhere in the in-between. I think we are seeing a real concerted erosion at that net because of repeated temporary gaps in funding. But at some point, going back to that analogy, you'll reach a threshold where now it's so weak that it eventually has a critical collapse.
How do we know when we've gotten there? You know, is this the pot of boiling water where you just keep turning it up a degree?
I think so, but I think we do have some early warning systems. I think that's one of the big roles for public health. We certainly have all of our disease surveillance and data monitoring that we are trying to continue to invest in. Talking about funding challenges, that's certainly one of ours on the public health side, is ensuring continued investment in that, because that really will be our early warning system. I look at certain topics in health as our early warning indicators, things like maternal child health outcomes. I know you talked about children, that is really a big indicator for us. Other things like chronic disease rates and poorer health outcomes, ER visits for chronic disease complications. So we have early warning systems, that's one of the things we do, are watching those trends. That we can really say we're starting to see some concerning numbers here.
We already have distressing numbers when it comes to maternal and infant health
That's right.
and care for a developed nation. David, the local impact on community health centers, as Medicaid eligibility rules tighten, where does that pressure show up first? Is it the front desk? Is it the exam room? Balance sheet? You know, those are your early warning.
Well, I think it shows up first in terms of the, because really people have to start with the eligibility. I mean, we'll provide care whether they have coverage or not, but I think one of the, with the Medicaid changes in tow here, one of the biggest issues is really around the eligibility part and what's going to be changing there, particularly with work requirements and with people now having to attest twice a year. So if you just think about that, the first thing it pinches, and I see Amanda here from Healthy Capital District, but we work with them to plant some health insurance navigators here to help us with that. We do some of it we do ourselves, but the bottom line is we will be doubling that workload next year because we handhold a lot of folks to make sure that they don't lose coverage again. It comes back to the fact that Whitney Young does a lot for them, but when we refer them out to other providers for diagnostic things, for specialty care, that portability of care is what allows them to stay engaged in care. We can continue to see them here at Whitney Young if that care goes away, but the rest of the specialty providers in the community, many of them will not be in a place to see them. So the continuity of care that we offer here is wonderful, but we create that continuity for that patient to be portable by making sure that we have turned every stone to make sure that they have coverage.
And I want to point out, we're going to have time for Q&A. So, Maria, I see you're nodding along with David. Do you want to jump into the conversation here?
Yeah, absolutely. And I want to put a finer point on one of the things that makes community health centers so unique is that they do serve everyone. And when you think about services like dental care, for example, especially in Albany, we don't have sources of dental care, preventive dental care, for those who are uninsured or on Medicaid outside of the community health centers in the region. And so what does that look like? I've heard from health centers in some communities, they have waiting lists for dental services of 4,000 people. 4,000 people. To fold in the workforce element, dentists classically have very, very high higher education fees, and in New York State undergo a residency where they're not being paid well for their first year right out of school. This drives people to private practices. Maybe some of you even in this room struggle to find a dentist. Now imagine you're uninsured. We've worked with the Department of Health. We hear that one of the largest drivers of avoidable emergency room visits is dental care. But there is no safety net for those individuals. This is as of today. As people start to lose care and you start to think about the pressures that that will have on community health centers like Dave's at Whitney Young, like Hometown in Schenectady, and the 80 others across the state, it is already unmanageable. And so you talk about warning signs. A 4,000 person waiting list for preventive dental care is pretty much the clearest warning sign that we have that the system is already frayed. And so I fear for what that means for children's dental health.
There's a pediatric dentist that I'm familiar with, and years ago, the dentist chose to provide care to the Medicaid population and had to put another staffer on just to handle the paperwork. So that's another salary and benefits, and that was one, and this has got to be 10 or 15 years ago. We were saying that time flies. So we can only imagine the cost and the burden to the dentist. And there were some that it was one I knew who stopped doing it for that reason. Kate, you want to jump in?
Well, I'll just reinforce that as oral health as a really important concern for Medicaid, but for everybody. And we recently put out a fantastic report with the Center for Health Workforce Studies looking at the gaps across the state. And not surprisingly, there are gaps in access to oral health care for everyone across the state, particularly in rural areas, particularly for seniors, and for people with intellectual and developmental disabilities. And so, and to Marie's point, the waiting lists, even in places where there's a free dental clinic, if you go to Rochester, Eastman Dental, or you go to Buffalo, people can't get an appointment. And, whether it's, thousands of people on the waiting list or a year waiting for an appointment. And that's for people who actually have a need. And I spoke recently with a person who's working in the emergency department here in Albany at a hospital, who said they had a young person, a teenager who had to have their tooth pulled because it had gotten so bad, because there just wasn't access to the kind of care they need. Now picture, kids having teeth pulled when they're children, and think of the pain that they're in. We know that's a common reason for missing days of school. So yeah, access to oral health care and the workforce needs are massive. And the dental shortage is a shortage across the nation. So we need to think of other ways to make sure that people can get the care they need.
We haven't even mentioned mental health care.
No.
Healthcare is healthcare is healthcare. And to that point, can you describe a specific patient population, families, seniors, people, and you've mentioned some of this, chronic conditions, who will feel these cuts the fastest and have the most impact?
I'll lead off on that if you'd like. I think that in New York State, I think the cohort that's going to feel that the greatest, and I'm factoring in all the work requirements and all the other things that are going to come into this, are really single adults with no children who have 2 or more chronic conditions that require them to stay engaged in care on a continuity basis. Because that's the group that will probably be targeted the first. And that often means also they have less supports in their life. So there's not often someone they can help, that can lean on to help them through that process. I think it'll impact every segment of the population we serve, because to Dr. Navarette's point, the pinch points start and you have to constrain in some way, shape, or form across the organization. It's not just, if it happens, say it starts in pediatrics, that means that some other place has to sort of be able to make up for, those losses and help mitigate the bleed. But I think that, in my perspective, that's going to be one of those, and that could be, folks with HIV disease, hepatitis C, again, just folks that have 2 or more chronic conditions, that have, worked in positions that have maybe allowed them to stay just above the poverty level, but not really get to a financially successful place where they can be more autonomous and more individually.
Your point,
secure.
I just wrote, make up for those losses.
Yeah.
I'm not sure how that happens if you're all facing those losses. How do you cover for each other? Can you?
I think that's the real challenging question at the moment, is I do think we're all facing losses and impacts on all sides, and so I think it's how do we think different, how do we be innovative and think collaboratively in a partnership. It's one of the things we're talking about as I think this is why a panel like this is so great. What is each of our roles, and so how do we make sure that each of us can maximize each of our resources that we do have left, to make sure that we're not duplicating, to make sure patients are getting where they need to go for the best spot for them, for whatever their needs are. I think we have to be smarter and innovative about it, because I think just doing the same is not going to work in this moment.
That's the zeitgeist changed. It is. And you all getting together and having that conversation and then deciding what you want to give up and what you want to take on and what you want to maintain. So are those conversations happening already in the community?
I think for us, yes. I think one of the things that's fostered that is, the state's pursuit of the social care network, or the social care waiver, that started about 1.5 years or 2 years ago, which, for the first time has monetized as a Medicaid benefit access to social care services, so to, housing supports, food insecurity, transportation, more than just Medicaid transportation. And so I think in our case, we've been working with those CBOs to actually have more embedded people within our own care environment. Otherwise, we have staff chasing those things, but they're not the experts. They don't know all the programs that exist. They don't have all the, the tight connections. And so having those people in our midst to be able to have those organizations really take that warm handoff literally from an exam room, when they've divulged to whatever clinician is working with them their impediments that they are too embarrassed to maybe raise elsewhere, that we can actually get on that very quickly, and that now there's some level at least of monetization of that Medicaid is supporting it. How long that will last beyond March of 28, we don't know, but at least in the moment, we can do a better job of, I think, putting those people in our presence to make that collaborative stuff work.
Yeah, and from where CHCANYS sits, I think there are a lot of tables that are set of really, really brilliant minds in healthcare and in public health in New York. Medicaid Matters is one of those tables. And I think that we're seeing a lot of different sectors, hospitals, community health centers, behavioral health providers, patient advocates, scholars, researchers are already coming together and have done so in the past and are sitting at those tables and talking about the path forward. One of the biggest challenges is that we are in an information vacuum in a lot of ways, and we're missing a lot of information about what this will actually look like on the ground. New York State is, of course, working as hard as they can with the information that they have, but their main constituency is the managed care plans in a lot of ways, and the patients. And so a lot of the providers that are sitting at the table and hoping to be that kind of go-between are looking for more information. And additionally, the information systems, the data, where will that exist? How quickly will providers get their hands on it? These are questions that we talk about with our health centers and our public health partners all of the time. And it's difficult to plan for something that's not fully worked out.
Community health centers are required by law to see patients, as you all pointed out, regardless of the ability to pay. So if more patients lose Medicaid coverage, and they're going to, it's not if, it's when more patients lose Medicaid coverage, but they don't stop needing care. How do health centers absorb those costs?
Well, that's the tricky equation that we deal with even before we
Bake
get to
sale.
Medicaid funds.
Yeah.
But I think, we do have some partners in the federal government that are on the other side of the table from where these decisions on the big beautiful bill occurred. And I think that one of the beauties, I'll steal Marie's thunder before she gets there. So one of the beauties of the community health center movement, as we celebrate it this week, is that it has enjoyed tremendous bipartisan support. So despite who sits at 1600 Washington or Pennsylvania Avenue, we've always been able to lean on those states that have particularly a lot of rural health centers where they tend to be redder. Because this program, the federally qualified health center program, supports rural communities, urban communities, any walk of life. And it's often been those folks that are a little to the right some years that have been able to lean on the right people to make sure that it's preserved. So obviously we'll advocate like heck to get our federal funders to try and step up and do this gap. Most recently in the legislature this year, Marie and her colleagues advocated to get a little bit of rate relief on the Medicaid side, which yes, you may have fewer Medicaid visits, so we won't get as much as we would, but we're going to get a little bit more. And so that was in anticipation of this, to be more proactive so that we would get some rate relief, knowing we were going to have to support some of these draconian measures that we're going to deal with. And I think with that as well, it really gets back, how do we deal with it? It gets back to kind of being a little bit more innovative about that care. And, we still need to push more to telehealth. We still need to push more to a little technology, not replacing entire roles with people, but really doing the things that we can do that don't require the human touch in the moment, but that require us to be available. So, just an example, in the last several years, the significant increase of people who do prescription refill requests with their provider that never come to the office to do it right. They're doing it through a patient portal or something like that. Those are the kinds of things that in a cumulative way make a difference, and so we have to be poised to push that.
I'm glad you brought that up, but you've got there is a population that one doesn't have access to the technology.
Yeah.
They just don't. And two, don't know how to utilize that technology. What happens? Are they just lost? Where are they? How do we serve them? Kate?
Well, I think I've been thinking about the fact that like the communities where community health centers are located are really those, and community health centers are in the eye of the storm right now.
Yeah.
And the way that stepping out beyond Medicaid, the way that the federal law that was passed last year is structured, it disproportionately harms low-income people and disproportionately helps high-income people. Per a Congressional Budget Office nonpartisan memo, very explicitly. And so what that means is not just low-income people, but those whole communities. So by definition, it harms low-income people, and then those very communities that are already under-resourced and that already have a high proportion of low-income people, which are by definition where the community health centers are located, are going to be disproportionately harmed by people losing their health insurance as well as their access to food assistance. So major cuts, in addition to Medicaid, to SNAP. And so I think, we all need to be thinking about those very communities, again, where health centers are located, as places that we need to look, whether it's through Medicaid or through other mechanisms, we need our state leaders to be really thinking about those communities.
I just think about Wi-Fi access.
Yeah.
We drove over to Vermont this past weekend, and once you get out of Salem, New York, into Rupert, Vermont, there is no Wi-Fi. And even from Greenwich to Salem, there were a couple of spots. So telehealth becomes no way to access. These are real, do you set up portable sites once a month? Do you go out in communities?
We do inform through the case management staff. We do inform people where there are access in the community, so the public libraries, a number of other organizations that we work with that have,
But David, let me jump in. Then you've got to go sit in the library and talk
Yeah,
about
and
personal
talk about
stuff.
your business, right? You know,
Right.
It's not great, so,
And
broad-
Mrs. McGillicuddy or Mr. Jones comes and takes a
Yeah.
look, and
So there are a few locations like that where we can encourage people, but I think, I'm always an advocate, frankly, of we need people in front of us. But when push comes to shove and we have to pick and choose, is nothing better than something, I guess, right? And so those are the things that we often tend to have to kind of gravitate to.
So I'm also hearing that there has to be education in these
Right.
hot spots where people will
Yep.
come to help ensure the privacy.
Right. So the other thing we do at Whitney Young is we have a couple of mobile health units, and so getting them out into the community, it's a more expensive level of care because you can't see as many people, and you're really not super limited because you still have that is Wi-Fi enabled, and you have the ability to pull down medical records and do all the things you need to do. But getting people to help host those stops when we go someplace and let their staff sort of help bring those people in and assure them that they can get a good level of access. I mean, that's one of the options that we have. I think during the pandemic, nobody wanted us to be there because they didn't want, that gathering. But I think it's vogue again, and I think it will be vogue again with some of the things that lie ahead of us. And not just for primary care, but I think also for particularly preventive dental care in the hygiene agenda.
And I would add, I think this is where that innovation and partnership comes in too. I don't think, we talked about in the beginning, all that additional pressure. I think solutions like telehealth, the mobile clinic, offsite clinics, those are all things to relieve the pressure of inpatient, or in person at a single site. And so I think that's the kind of innovation and partnership where we think about some of these different solutions and bring them all together. No one solution is going to be perfect. We're going to need lots of different solutions. I think
And solutions
telehealth
we
is
haven't
one.
thought about yet.
That's right.
But again, like back to the CBOs I talked about that do a lot of the social care needs, meet them. They have offices, places, the patient's ability to be there for them to get plugged in a room, us supporting the technology to do that. Again, however we can get that connectedness and to your point, to that information security, I think those are things that I think are doable and probably things that organizations that support us would be willing to support.
And then you've got that underlying trust issue.
Yep.
That you struggle with anyway, that then becomes heightened. Kate, the Schuyler Center is the home of Medicaid Matters New York.
Yes.
What's the one policy change on the table at this moment that you think the public most misunderstands or hasn't heard about?
Well, I'll start by saying Medicaid Matters New York is the statewide coalition of individuals and organizations focused on the Medicaid consumer. There's a lot of lobbying that goes on related to health and healthcare, and most of it's focused on not the people who are covered by it. And Laura Castle here is the coordinator of Medicaid Matters New York, and Medicaid Matters home is at Schuyler Center. And I think one thing that I just want to sort of lift up, because we've talked about some of the, loss of eligibility, work requirements, more frequent redeterminations. I think also we need to be thinking about people in immigrant families. So 38% of New York's children, 38% of New York State's children live in immigrant families. And we hear a lot of the rhetoric around keeping illegal immigrants or unauthorized immigrants off of benefits. That was already the case before last year's bill passed. And so in addition to what's happening in immigrant communities where people are afraid because of immigration and customs enforcement and other types of things like that, the federal law that passed last year changed eligibility for a whole lot of programs. Again, undocumented immigrants were already ineligible for most programs, but there were rules changes that eliminates more immigrants from Medicaid coverage, Medicare, SNAP, and even the child tax credit, which is something that our organization works on because of the importance of family economic security to health. And so in addition to sort of what's happening out in communities with regard to fear and chilling, people in immigrant families, and that includes a lot of citizens. I mean, whether you care or not, but that includes a lot of citizen children who are in families where they're being denied access to health care and food and a feeling of safety, which is likely to lead to health and other problems later in life. So that's something that I think we're not paying enough attention to. Even though I think there's some attention to the ICE stuff, there's this other underlying sort of loss. And in many of our communities, that's a lot of our kids and a lot of our families.
And there's a cost on the back end.
And there's a significant cost on the back end here in our own communities.
Marie, CHCANYS represents health centers across the entire state. So what is happening right here in the capital region typical? Or are there things about this region specifically that either make it more or less exposed to the changes ahead?
Yeah, I mentioned in my opening remarks that at CHCANYS we've done some analysis about what this will mean for the 80 community health centers across the state. I mentioned $300 million in annual losses. It might be hard to conceptualize what that actually means for a network of primary care safety net providers. That's about 11% of their total revenue. Medicaid is the single largest payer for community health centers across the state, and in Albany we see that the rates of patients on Medicaid or who are uninsured are higher than other areas of the state. So while I wouldn't necessarily say that it is unique that the health centers in Albany serve Medicaid and uninsured patients, because of the high volume of Medicaid patients in this area, it will uniquely harm this area. And compounding those effects are some very wonky payment issues where actually the providers in the Albany area get paid much less than the health centers in other areas of the state. And so that's something that we've been looking to rectify for a long time, long before my time at CHCANYS. But when we talk about the compounding effect of these years and years of disinvestment, underinvestment in communities, Albany is no stranger to that. And Whitney Young specifically has been picking up for a lot of providers that have packed up in the area. And so this, while maybe not uniquely unique, Albany certainly has its own story in this.
And to that point, Commissioner, is there a role for county government to backstop some of this, or are counties themselves financially strained by the same forces?
Yeah, that's a really challenging topic. So there's absolutely a role for county government. I talked earlier about some of the data and surveillance systems, early warning signs, and some of our role in convening and partnerships. We also have a lot of programs and services that are designed to do a little bit of that backstop filling. And so we have services that we offer at the local health department that are providing some of those safety net care, just like Whitney Young does. We have our own pediatric dental clinic. That is our most robust service. We have patients in there every morning and every afternoon. It's hard to make sure that we're able to give all the care that we can because there's such a need in this community for children's oral health. We also do things like tuberculosis care. That is actually a little unknown, is that we really don't have a robust network of healthcare providers that are willing to provide tuberculosis care, and that care is becoming increasingly complex. So, we certainly use our data and systems to understand where some of those really critical gaps in care are happening, and then work to be able to provide them. But, you really articulated it well, that we are also facing our own challenges. I think the really most challenging part of it for the county is that, we're not just seeing it in healthcare, these funding gaps. We are seeing it across all of the human services systems. So whether that's SNAP, some of our other children, youth, and family services, we're all seeing funding challenges. And so there's no way that the county can possibly absorb all federal and state funding to be able to help fill all of the backstop. But it's where we got to work together.
I'm going to open it up. Just, you talked about TB, and people don't think about that, and we don't, But you may have caught an article that Florida has seen the largest number of leprosy cases ever.
Yeah, we're definitely seeing a return of things that we didn't previously talk about. We are seeing an increase in tuberculosis. We're certainly seeing an increase in measles across the state, and other communicable diseases that we just didn't talk about before. I read that diphtheria is becoming on our radar again.
And with the change in climate, whether you believe it or not, we're also seeing mosquito-borne and tick-borne diseases that we hadn't seen. Lovely, isn't it? It makes you want to just keep the blanket over your head. I'm also the timekeeper, so it's time for us to open this up to all of you. If not, because I'm the Grand Inquisitor, I always have another. Please, yes.
So Dylan McCoy with Assemblymember Steck's office. So he's chair of alcoholism and substance abuse. What impact do you think especially the work requirements are going to have on that field, and also, the access to services that people will, have for recovery treatment?
It's like the first pitch at the ball game.
Go ahead, Marie, if you want to take us.
You want me to jump in?
You
Yeah.
can have
Absolutely.
CHCANYS perspective on it.
Sure thing. So one of the things that we're still waiting on more information about is, what do Medicaid work requirements, what will they really mean for people with substance use disorder? Right now, it looks like people with substance use disorder may be exempt from Medicaid work requirements, but it depends on how long they're in recovery, whether they have other chronic conditions. How will someone document sensitive details about their substance use disorder and provide that information to the state or their provider? Will they even be able to get that information to the state, to their provider? Or will they throw their hands up and say, you know what, forget it, maybe I don't need Medicaid. And so those are some of the really big unanswered questions that we have. Same thing for behavioral health. Behavioral health conditions could be exempt, but does that behavioral health condition actually impede that individual's ability to work? And who decides that? And so these are the things that we're hearing, especially from our clinical providers, are causing immense stress and anxiety, because they don't want to be responsible for making that determination that someone's behavioral health condition does or does not impede their ability to work, such that they should be exempt from the Medicaid work requirements. We don't have to overstate that these populations are vulnerable, and the hoops that they will have to jump through, that is part of the reason why we expect many people will become uninsured.
Mm-hmm. Yeah, unfortunately, we're hearing the same thing from providers that they're asking us. So it's interesting to hear that everybody's in limbo, and it's not kind of just us that we're having to tell people that we don't know, and it's not the answer that they want to hear. But
it's agonizing.
Yeah.
Yeah.
I just think of somebody who's on methadone or Suboxone and has to spend 2 hours at the clinic waiting, and how that impacts their workday, and whether the work provider, the employer, will understand that and keep them on the payroll, so then they can continue to get their benefits.
So
Yes.
I always like to think there's at least some silver lining in misery that's inflicted upon. So for that population, I do believe it will encourage folks with substance use disorder to perhaps get a bit more engaged in the primary care agenda, because to Marie's point, we're probably going to be in the determination business, not just the primary care business, but the ability to kind of look at, again, the whole person, not just their substance use disorder, presentation, but the other things that they may have not attended to, that we might actually be able to get some folks now, if we have people to put them in front of, but to engage them better in the primary care as well as in the mental health agenda. And we could probably be here for another 4 hours talking about whether we should put Oasis Snow Beach together and that. But as we cost cut, we may think about that.
Everything you said, there's a whole nother avenue.
Yeah.
All these doors keep
Yeah.
opening.
Yeah.
Yeah, it's, please.
I just wanted to kind of piggyback on that. I work in cancer care, and, you know, our fear is that, you know, just as with mental health, we have a population that cannot work. They're in active treatment, they're in chemo, they're going to radiation. We're already seeing people that are losing their jobs because they're not meeting attendance requirements. So has there been any kind of thought process on, you know, people who just physically, there's no way they can meet those requirements even if they wanted to? I mean, and also people who are on active treatment that are losing insurance in the midst of treatment, is there kind of a thought process for how we can help?
I will say, and maybe Laura has more to say on this, I want to just call out that I feel like we here in New York State are in a better position than some of our, because the state, you know, Medicaid is funded partially by the feds and partially by the state. And so the state has to adhere to the federal rules in order to get our federal funding. But the state plays a significant role in implementing eligibility and payment and all the other stuff. And our New York's State Department of Health has made very clear that they are working hard to try and figure out how to meet the new federal requirements and keep as many people covered as possible. So, I mean, that's underway right now, but, and I don't know, Laura's more in touch with some of that than I am.
Thank you.
Just tell us who you are.
Sure, I'm Laura Castle, I'm the coordinator of Medicaid Matters New York, which, as Kate said, is housed at the Schuyler Center. A little bit of nuance that I'll add, although Marie did a really good job already of describing this uncertainty that we're all sort of swimming in right now, because the state, as they keep saying at every briefing and every convening, they're building the ship while they're sailing it, and they're figuring out all of this in the midst of implementing something that's going live January 1. And going live January 1, by the way, means that the notices are out now. So I think of a little bit of information that I think could be helpful. In this first year, starting January of 2027, the basic way to think about this is the state will have to rely on data that's currently available to them to verify that someone is working or meets an exemption. And so that could be someone with a substance use disorder, that could be someone who's in cancer treatment, or anyone else. And first, that's the first step. And then in the first year, they will allow people to self-attest. So that's, I think, a very, regarding work reporting requirements, a very basic, important thing to understand is while they're implementing all of this, you know, building the ship while they're sailing it, there are these pieces that will allow them to have a little bit more runway, and the self-attestation is one, where in the first year, if for some reason the data that they're working to set up now isn't working for someone, they can say, it looks like we don't have anything to verify anything for you, so please just self-attest. And I could say a lot more. As Kate said, Medicaid Matters is very engaged on a lot of the changes that were enacted in HR 1, the big bad bill that was described. And so there's a lot that we're trying to stay on top of and include in our advocacy.
And actually, we have a good fact sheet on the Medicaid Matters New York website and on the table.
And I would add, I think this is where the care navigators are really going to become critically important when we're looking where we can, you know, try to support best. It's going to be those people who know exactly when it comes for reauthorization and renewal, what is all the paperwork requirements. I think those who are going to need these services, it's going to be very complicated for them to understand on their own, and so how we can support many of you who I know are doing that is going to become a really critical piece of making sure that we can keep people enrolled.
Question, please.
So So Amanda with Healthy Capital District. I know a lot of our conversation focuses on Medicaid, but Dave also brought up a great point about those other individuals. So over the last month or so, in our organization alone with about a handful of health insurance navigators, we had over 1,100 people on the Essential Plan 2 that lost coverage or had to make a decision to choose a plan that now has a premium and a deductible and a coinsurance. So from that, we know that those individuals, a lot of them unfortunately may have signed for a plan and aren't going to be able to pay the premium, or they're going to be cut off suddenly, or they're not going to seek care, or they're going to seek care and not be able to pay their deductible or their coinsurance. So I'm just wondering from anyone, how or can we prepare to serve this population that really, they might be showing up now with more acute needs, and also they really aren't going to have that coverage. How do we prepare, collaborate, support that population?
I think this is such an important point because you're right. There are so many different things going on with different kinds of insurance as a result of HR1, as I call it. Not just the Essential Plan, which is, for those who don't know, non-Medicaid insurance for extremely low-income individuals often has included no cost sharing. As individuals have been shifted off of those plans, as this individual has said, they're looking at the insurance marketplace. However, in the insurance marketplace, we've lost subsidies. And so the prices are also rising there. And the insurance marketplace famously has extremely high costs already for an individual, for a family. So we have so many buckets of people, those who are already uninsured, those who are newly uninsured because they've fallen off the Essential Plan, immigrant populations who will be losing their insurance eligibility. New York State may pick some of those people up. And then those who are now underinsured. And the underinsured will be increasing such that community health centers, two community health centers like Whitney Young, they are effectively uninsured because they cannot pay their deductible for services, so they become self-pay. They come to our health centers, they come on our sliding fee scale, they may or may not ever pay. And so this is why, of course, in my seat, I see community health centers as the real answer because they will continue to be there to serve those individuals. Public health in the same way for the services that they can provide. But when we look to the specialty care and we look further out in that safety net, that's where things really start to fall apart because we don't have systems where there is additional support for those who are paying out of pocket for care. Some people can't even be seen at the door. So I think we need to absolutely continue investing in community health centers and public health. That, to me, is at the top of the list. New York State has done some of that last year in its budget, but we know that it won't be enough. Public health has been underfunded forever.
Decades.
Forever, forever, and getting worse. And that's certainly an area as well that we need to see New York State to start making some really smart investments in the safety net so they can provide that care. But it won't be enough. And that's the unfortunate answer to your question is when we look out further into that system, the Whitney Youngs can't do it alone. And local public health can't do it alone. And even together, we can bring as many community-based organizations to the table, but this is a system of underfunded nonprofits and public entities that are trying their best with what they have. But this is exactly what we're talking about with the safety net fraying.
I've got one question to wrap it up, but it's the positive, but the negative side before I get there is at some point there will be community health centers that have to close their door.
Yes.
Because if you can't pay your bills,
Yes.
you can't stay open. It's just that simple.
Yes.
Well, with that in mind, to all of you as we wrap, what gives you hope even at a time like this? And I'll start with you, Commissioner.
I think what lets me sleep at night is that this is a strong, committed, passionate community, right? You look at a table like this, all of you out here, the challenges are immense for sure, but it's an innovative, committed, passionate group of people in this community who are committed to really doing the right thing. I think we talked about, yes, people will close their doors. I've had conversations with the health systems, they also do charitable care. At the end of the day, everyone's on the same page. We will take care of the people who need to be taken care of, and then we'll figure out how to fund it. It gives me hope that, if we can get us through the next short term and midterm, it will give us some time to build a better system of the future that's more sustainable.
Dave mentioned that this week is National Health Center Week, and with it, we're celebrating the decades of history in the health center movement. The health center movement was born out of the civil rights movement and this belief that everyone deserves equitable access to high quality care, and that care should be directed by the community that it serves. And so what gives me hope is that we started from a small individual health center in the South and have grown to a movement across the entire country that's serving, as I said, 2.5 million New Yorkers and over 30 million people across the country. And so I have to believe that we will last for another 60 years and more, and that, just as Dr. Navarette said, this will position us to build a bigger and stronger safety net in the future.
I am hopeful because I think we live in a state where there's an understanding of the many things that contribute to people's health, and that's evidenced in our Medicaid program and our waiver that tries to address social care needs. It's evidenced in the state's legislated commitment to cutting child poverty in half in 10 years because of an understanding that poverty and low income can have significant repercussions for a lifetime, including health repercussions. And I feel like, for those of us who are sort of in this room, these challenges that we're having right now are why we do the work. And that gives me hope, like having a community of people who are in it because this is why we do the work.
So I'd probably reiterate a little bit of my three colleagues' comments, because I do think we have a pretty supportive environment around us here, and certainly at the state level, of commitment to, today we focused on Medicaid, but I'd like to say pretty much every constituents we serve at Whitney Young in the last 2.5 years has had a target on its back. So whether that's somebody who's wasn't born in this country, whether that's someone who is wrestling with where they'd like to be a year or 3 from now with their sexuality, whether it's folks that are living on the margins financially. Pretty much everybody we see has a target on their back. And so to see the rallying around of various constituency groups in this effort, it's been tremendous. And again, to the state we live in, I always give people the example, it could be worse, we could live in Texas. If you are in Texas and you are a single individual, you can't make more than 40% of the federal poverty level and qualify for Medicaid, which means you have to live on less than $5,200 a year. We're at 138% of poverty, so do the math on that to qualify. So those things do give me hope, but I think a lot of it is also driven by, at least in my environment here day to day, is by the people, the number of people that we have here at Whitney Young that have given a crap for a lot of years and are going to keep doing that, and that put those people first before a lot of the other issues in their life, and a board that has been incredibly supportive, and yes, it changes year to year and every 3 years, what have you, but it's those folks that have invested in this organization and the work we do, and again, just colleagues that we know we can lean on. And I kind of go back to the darkest days of COVID, and 3 times a week I was on the phone with Liza Whalen trying to figure out how we together could do those things. That never happened before that, and so we've seen adversity in a different way, but I think it's through that adversity that we have all become a lot stronger. So if that's any bit of hope, I feel it is for me.
As I say to my clients when they really have succeeded, I go like this. And then they all laugh, and that's great because we release endorphins. And endorphins are our feel-good hormone, and they boost our immunity, and we all need an immunity boost. And I get a quick, cheap workout of my triceps. Because we all have to multitask these days. Commissioner Navarette, Marie, Kate, David, I want to thank you all so very much for your time and your expertise and your bit of hope as well. But we all have to put our oars. The takeaway is everybody's got to put their oars in together and have conversations and be in contact. This is not something that we can do alone. Silos will not work. So thank you all for coming today, sharing your energy here, and go forth and be well. Thank you very much.
Thank you.
I could just add a few little remarks here. We do have some lovely snacks over here if any of you would like to stay, network, ask additional questions. To the panelists, thank you all for being here this morning. We appreciate you. And to my dear friend Benita, thank you so much.
You're very welcome. And I have one thing I forgot to do earlier. Thanks to CDTA for being a sponsor of this today.
right on.
Thank them very, very much. So,
Thank you all. Please enjoy the rest of your day, and please network and enjoy. We'll take care, and we'll see you all very soon. Thank you.
Taking a video about